Hi, this is Lynn Keurig, and we're going to be talking about leukemia. So when we talk about leukemia, we're going to start with a definition of leukemia. And the definition of leukemia is really a neoplasm that's going to rise in the bone marrow, and then it's going to spread to the peripheral blood and throughout our body. So leukemia really has a common feature of all leukemias, because we're going to talk about different types of leukemia, is really an uncontrolled proliferation of malignant leukocytes, which really causes an overcrowding of the bone marrow and a decreased production and function of our normal hematopoietic cells. So we're going to talk about the different types of leukemia. And the types of leukemia are really classified based on the predominant cell of origin, the rate of progression. And when we talk about the rate of progression, it's really going to show us how it reflects the degree at which cell differentiation was arrested when the cell became malignant. And we can see that either acute or chronic leukemia. So there's 4 different kinds of leukemia. Our acute leukemias are really characterized by undifferentiated or immature cells. Usually it's a blast cell, and usually the onset of disease is abrupt, and it's pretty rapid with a very short survival time. And our 2 types of acute leukemia are acute lymphoblastic leukemia, or ALL, our acute myelogenic leukemia, or AML. In our chronic leukemias, what normally happens here is the predominant cell is more differentiated, but it does not function normally, and it does have a relatively slow progression. So our chronic leukemias are going to be chronic lymphocytic leukemia, or CLL, and our chronic myelogenous leukemia, or CML. So we're going to talk about when our patients come in, what are the initial symptoms that we're really going to see in these patients? What kind of complaints might they have? Our patients can come in with some simple symptoms such as increasing fatigue. They can complain of some inactivity over the past 2 or 3 months. They might complain of some bleeding. It's usually related to the thrombocytopenia. They might complain of fever. Fever we might see in an infection, and sometimes it can be dramatic. It can be overwhelming, such as sepsis we might see in some of these patients. We might see weight loss. A lot of them will complain of some abdominal pain or discomfort. They might complain of feeling full all the time, and which leads to their decreased appetite. They might have some bone pain, and that can result from the expanding leukemic cell masses within their bone marrow. They might also have some neurological symptoms, and their neurological symptoms can be anything ranging from a headache to seizures. They can have some cranial nerve palsies, and it's usually caused by that leukemic cell infiltration of the meninges. Next, we're going to talk about the epidemiology. Leukemia can occur with varying frequencies at age groups, and it's more common in adults than in children. And it's really estimated that there's approximately 30,000 new cases of leukemia are diagnosed each year in the United States. And CLL, which is a chronic leukemia, is the most common, and that accounts for about 15,000 cases annually. It occurs most exclusively in the patients over the age of 50. The median age of presentation for our CML is 45 to 55 years of age, and for our AML is around 65 years of age. And we've seen that over the past 2 decades, the rate of readmissions and survivals in most forms of leukemia have increased. Our current survival rates for AML are about 24%, and for our CLL, which is our chronic leukemia, is about 81%. And our survival rates for children are even greater than that. Our CLL for children is about 91%. So we're going to talk a little bit about the etiology and the pathophysiology of these patients. And when we talk about leukemia, in most cases, the cause for leukemia is pretty much unknown. There have been some certain environment exposures have been associated with the hematological neoplasms, such as our radiation exposures for our CML and our AML. And this appears to be related to survivors of the atomic bomb in Japan, and it really showed a peak incidence over the years after exposure. Chemotherapy, some of our alkalining agents have risks of AML, our acute cases. Some chemical toxins, such as an Agent Orange from the Vietnam War, have been associated with the chronic leukemia, and also myelodysplastic syndrome. And many of these cases of AML have been preceded by myelodysplastic syndrome, and it's also really associated with chromosome abnormalities. Also, some things to keep in mind, it does show increased risk in adults who are exposed to cigarette smoke. Any ionizing radiation also does increase the risk. So we're going to talk about what could be some differential diagnosis. When we talk about our differential diagnosis, we're really looking at the elevated white blood cell count. So we're looking at the differential diagnosis, which could include leukemia. It could include a leukemoid reaction, and this normally can be caused by an overwhelming infection or a paraneoplastic syndrome. We can also see demyelination of our neutrophils, and this can be related to something as simple as a physiological stress, or it could be related to corticosteroids. So now we're going to talk a little bit about our diagnostic evaluation. And what is our diagnostic evaluation? What we're really looking at is our white blood cell count. That's really where we're going to be seeing any kind of changes there. And what we're looking at is the elevated white blood cell count. And normally when we talk about our elevated white blood cell count, it can be anywhere from 15,000 to more than 100,000. And it's really the hallmark sign of leukemia. We also want to be looking at a peripheral smear. And what we're going to see in our peripheral smear is our myeloblast in our AML. And usually we're going to see thrombocytopenia with those patients. We're going to see that our blast cells have predominantly nuclei. They have large nuclear to cytoplasm ratio and a lack of granulites. We're also going to be looking at our bone marrow biopsy. And when we look at our bone marrow biopsy, that's really the definitive study for leukemia. And it really demonstrates greater than 20% blast cells in our AML. Bone marrow biopsies in our CML usually show a hypercellular marrow with an increase in our myeloid cells, and cytogenic testing reveals the Philadelphia chromosome in over 90% of these patients. Additional laboratory tests that we might see some abnormalities in would include our hemolytic anemia. We might see that in our chronic leukemia, our idiopathic thrombocytopenia, and that might be in our chronic, and our disseminated intravascular coagulation, and we might see in our acute patients. So what is our treatment plan really going to be for these patients? When we talk about our treatment plans are really going to vary depending on the patient. So chemotherapy is really the treatment of choice leukemia, and it really uses varying combinations when we talk about our chemotherapy. We have for some of our chemotherapies, we have a lot of intravenous chemotherapies, and also for our CMLs, there is now a PO medication, Gleevec, which is a specific indicator of our BCR, and we use that in our CML patients, and it does show that these patients do have a 70 to 90% response who respond when they have failed from other interferon treatments. We also can do supportive measures for these patients. We're doing increased blood transfusions, antibiotics, antifungals, and antivirals. Bone marrow transplantation has been the standard treatment for our acute cases, and we also do see some stem cell transplantation done in these patients. So we are coming up with some new treatments. A lot of these patients our chronic patients can live 10 to 12 years longer. We are seeing them go into some remissions. So we are seeing some good outcomes in some of these patients. Bone marrow transplantation has been increasing over the last 2 decades, and it's really increased for our ALL and our AML. It does show the survival rates, the 5-year survival rates have gone up to like 89%. Which is really a remarkable improvement with our leukemic patients. We also can have some stem cell transplantation, and our outcomes for stem cell transplantation seem to be very well too. So we're going to talk about our case study, and our case study is going to be Bruce Story. He's a 48-year-old male who has a history of recent weight loss, which he has been trying to lose weight over the past year. He's lost over 100 pounds. He came in with some complaints of abdominal discomfort. He came in with some fullness that he does feel that he resulted in a decreased appetite. He has noticed that he has increased fatigue, that he has inactivity over the past 3 months. He does wake up with frequent night sweats. He does have some mild shortness of breath. He is complaining of some neuromuscular, musculoskeletal pain. So when we look at his history, he does have a history of multiple myeloma, which he did receive chemo and radiation for. He also has a history of high blood pressure. When he comes in to see us, he's alert and orientated. He's able to answer all of our questions. He is complaining of that abdominal pain. He does have some abdominal tenderness. He is positive for increased weakness and tiredness. He is positive for his night sweats. He is having shortness of breath. He denies any kind of headaches, any vision pains, no nausea or vomiting. His vital signs are within normal limits. His blood pressure is 122/60. His heart rate 63. Respirations are 22. His temp is 97.6. His lungs, he does have some expiratory wheezes. He is short of breath again, as he said, with any kind of exertion. He has been acting neural-wise. He's alert and orientated ×3. He has no neural complaints. He has a normal gain. He has full range of motion. So when we look at his labs, we do a white blood cell count, and his white blood cells are elevated at 123,000. His hemoglobin is 10.3, and his hematocrit is 33.8. We do a bone marrow biopsy, and his bone marrow does show hypercellular activity and extensive proliferation of his granulocytes. So we do know that when we look at his bone marrow biopsy that he does have chronic myelogenous leukemia. And when we look at his history, we can see that he had chemo and radiation from his multiple myeloma in the past, which would show that he probably has his etiology is probably related to, it's probably chemo-induced chronic lymphocytic leukemia. So we're really going to treat him. What we're going to do for him is we're going to monitor his lab work. We're going to put him on some Gleevec. Gleevec is an oral pill that he's going to take on a daily basis. We're going to watch his, we're going to see him about every 2 weeks for the first couple weeks. At the 2-week follow-up, we want to look at his white blood cell count. We want to do a 4-week follow-up. And we want to do lab work. We want to look at his BUN and his creatinine, his renal function, any kind of cardiac issues. We want to get a echocardiogram so we can see what his ejection fraction is to start, because we do know that some of these drugs can lead to